once again to the class. Today we are here to discuss about the disorders of purine and pyrimidine nucleotides in the subject Biochemistry BP 203T. In the previous lectures we have discussed about purine nucleotide metabolism and its regulation and degradation, about purines and pyrimidine both, and today we are here to discuss about the disorders of purine and pyrimidine nucleotides. So, let us begin with the lecture. So, let us revise a quick revise that nucleotide, that there is a nucleotide as made up of three things, that is nitrogenous bases, pentose sugar and a phosphate group. Nitrogenous bases, that are purines and pyrimidines. In purines there are adenine, guanine, whereas in pyrimidine cytosine, thymine and uracil. Thymine is in case of DNA, whereas uracil is in case of RNA. There is a sugar moiety, that is pentose sugar, different in both the cases. In DNA we have deoxyribose sugar and in RNA we have ribose sugar. What is the difference between ribose and deoxyribose? That there is an incorporation of oxygen in ribose sugar, whereas there is no oxygen present in deoxyribose sugar. That is, you can see here at the second carbon. And we have one phosphate group, then we call it, the compound will be called it monophosphate. If we have two phosphate groups there, then it will be called as diphosphate, and if there are three phosphate groups are there, then it will be called as triphosphate. So, we have purine ring, we have studied about our purine ring, we have studied out about our pyrimidine rings. Now, we are going to study about the diseases of purines and pyrimidine nucleotides. So, first of all we are discussing about the purine nucleotide. The degradation product or the last product of purine nucleotide is uric acid. That means adenosine, inosine and guanosine, all three when degraded into, degraded means when they are catabolized, when they are broken down into their ions, their byproducts, then it will be, the last product will be your uric acid. And after the formation of uric acid is easily excreted out from our body through urine, and this uric acid is completely water soluble. So, there is no problem in excreting this uric acid from our body. As we are aging, as we have seen our elderly people with so many joint pains. So, they mostly, because this joint pain is arthritis, a kind of gout, that is a kind of arthritis. So, this uric acid deposition will cause gout, which is a type of arthritis. Arthritis is joint pain. We will discuss it on later on slides. So, here is the, we are here to discuss the disorders of purine nucleotides. Uric acid is the end product of purine metabolism. The normal concentration of uric acid in the serum is about 3 to 7 micron per deciliter. In women it is slightly lower, it was in the case of men, and in women it is slightly lower, about 1 mg than men. That means, if they are having 3 to 7 mg per dl, then women will have around 2 to 6 mg per dl than men. The daily excretion of uric acid is about 500 to 700 milligrams from our body on daily basis. So, the first disease which we are going to study about is hyperuricemia. First we need to know what is it means. Hyper, if we divide this full word into two parts, actually into three parts, then we will have our three things, that is, one is hyper, hyper means elevated forms, more, uri comes from the word uric acid, and semia is, you have heard about anemia, it has emia in last, in the suffix of the word, that means in blood. So, here we can see that there is emia, presence of emia, E-M-I-A, that means here we are also talking about blood. So, hyperuricemia, what it will mean? Hyper means more, uri means uric acid, emia means in blood. If we see hyper, elevation amount of uric acid in blood, then the phenomenon will be called as hyperuricemia. It is very easy to understand. We need to just divide the word into certain parts and then we will know what is it means. So, hyperuricemia means elevation in serum uric acid concentration. That means there is a increased amount of uric acid present in our blood, then it will be called as hyperuricemia. And there is already a word which is similar to our hyperuricemia, that is uricosauria, or later on we will discuss about hyperuricosauria. Uricosauria, uric, let us divide it into two parts, that is uric and urea. Uric, that is from our uric acid, urea, that is from urine. If we see elevated amount of uric acid in urine, then it will be called as hyperuricosauria. If there is a disease in which we can see the person is having excreted huge amount of uric acid through urine, the person will have hyperuricosauria. Hyperuricosauria is an advanced stage of hyperuricemia. That means the person will first have hyperuricemia, later on he will have hyperuricosauria. Everything is correlated. So, uricosauria means presence of uric acid, actually increased amount of uric acid in the urine. So, everyday basis we excrete some of the uric acid from our urine, which is normal, that is mentioned 500 to 700 mg of uric acid we excreted on every day. If there is an increased amount of uric acid excretion from the urine, then the person will be hyperuricosauric. That is uric acid excreted in man, if it is more than 800 mg per day, then the person, the male, will have uricosauria, that is hyperuricosauria. And if in women it is more than 750 mg, then the women will have hyperuricosauria. Now, what will happen? What is the problem with this thing? Hyperuricemia, that means a person is already having elevated amount of uric acid in the blood, which will turn into uricosauria, or you can say uricosauria will associated with hyperuricemia, because then we will see huge excreted amount of uric acid through urine. That means the person, either woman or man, is having more amount of uric acid in their body. So, there is a huge possibility if a person is having higher amount of uric acid in blood and he is also excreting out that uric acid through urine. So, there is a accumulation of uric acid in body also, because there is hyper amount of uric acid production is there. Okay. So, what will happen if there is a deposition of uric acid? Those uric acid deposition will ultimately converted into gout. Now, what is gout? First disease we have studied, that is hyperuricemia. Next disease we have studied about uricosauria. In that uricosauria we have studied about hyperuricosauria. Next stage, that is our next disease, is gout. What is gout? Gout is a metabolic disease in which there is overproduction of uric acid, and this overproduction is uric acid. First of all, our body will try to compensate the production of uric acid. We will see the blood serum with elevated amount of uric acid, then we will see the urine with elevated amount of uric acid, and then what will happen, a stage will come, there will accumulation of these uric acids on the joints of the body, because joints, if you have seen the diagram of joint, a normal joint, it is like this form. That means this is a joint, and here is the synovial fluid, the fluid which is making the joints easy to work on. Now, what will happen if this uric acid will deposit in these joints, in between two joints? What will happen? Eventually what will happen, the fluid present in between the joint will get dehydrated, will starts to the joint will starts to swell, because there will be less amount of this fluid present between the joints. Now, if there is a huge amount of uric acid present in the joint, then and there will be less amount of fluid present, then it is very difficult for these joints to move on, okay, because there are certain crystals, certain amount of uric acid present. This is also called as the deposition of uric acid will be called as tophi. When there is a deposition of uric acid on the joints, on the soft tissues, then the phenomenon will be called as tophi. If there is presence of tophi between two joints, it will be very difficult for moving the joints, it will be very painful. That is why elderly people, people with excreted amount elevated amount of uric acid in the blood, in the urine, will have eventually will have gout if it is not corrected on time. So, the gout is a type of arthritis in which the person will have pain when he or she will try to move their joints. So, here we are talking about gout. Okay. So, this tophi are made up of crystals of uric acid, that is calcium crystals, oxalate crystals of uric acid, and they are deposited in between the joints on the soft tissues. Next, see what will happen. Then the sodium urate or uric acid, the uric acid will be in the form of sodium urate crystal, may also precipitate in kidneys and ureters, that result in renal damage and stone formation. So, there is a huge chance, if a person is having kidney stones especially, then that person is going through excreted amount of uric acid formation in the body, which the kidney is trying to excrete out. What is the work of kidney here? Kidney is a filtering agent, it is doing the filtration of the urine from our body. So, there is in the filtration process, there will be deposition of these crystals, these sodium urate crystals, and there will be formation of kidney stones. So, a person who is developing an elevated amount of uric acid in the blood, then in the urine, is most probably having kidney stones, or eventually he will be going through a disease, a metabolic disease called as gout. Let us see more we know about gout. So, there are two types of gout, one is primary gout and the secondary gout. Primary gout, or you can say it is the inborn error, that means a person who has born with this type of disability, that means he is having metabolism disability, increased synthesis of purine nucleotide will cause this primary gout. PRPP synthetase, that is improper feedback mechanism here. What are the reasons for that I am talking about? First is here, this is an inborn error, that is a metabolism inborn error. The person having metabolic problem when there is an increased synthesis of purine nucleotide. Second, what will happen then? The person will have PRPP synthetase improper feedback mechanism. I told you that all the things, that is purine synthesis, pyrimidine synthesis, all are controlled by your feedback mechanism. Then what will happen? Your PRPP glutamyl aminotransferase transferases enzyme is again having your improper feedback mechanism. the enzyme HGPRT, that is which causes the Lesch-Nyhan deficiency of this causes the Lesch-Nyhan syndrome. This is again we have seen in the primary gout. Then decreased utilization of purines by the Salvage pathway, and last is if there is a defect in Salvage pathway, then we can see this primary gout is happening. What about the secondary gout? The secondary gout is all due to our habits, is all due to the diseases which are associated with gout, the uric acid production, like various diseases. What diseases we are talking about here? That is increased synthesis and decreased excretion of uric acid. Any disease which causes increased synthesis and decreased excretion of uric acid can give you gout, secondary gout. Then increased degradation of nucleic acid. It is happening in certain type of diseases, in certain type of cancers like leukemias, polycythemias, lymphomas, and one more disease, that is psoriasis. That is increased tissue breakdown, trauma, starvation conditions are there, in which we can see there is a huge chance of secondary gout. So, primary gout is an inborn error. If we can fix these problems, then we can fix our primary gout, which is like you are on medication for a long duration. Then secondary gout, we can change, we can modify the secondary gout with certain medicines and daily habits. Pseudogout is one more thing. Pseudogout is a condition kind of gout, but in gout there is a deposition of uric acid, sodium urate crystals, but in pseudogout there is a deposition of calcium pyrophosphate. I told you in the previous slide, because there is a when we were discussing about sodium urate crystals, I told you that there is a deposition of oxalate calcium crystals. So, the calcium crystal we can see in pseudogout. If there is a deposition of calcium pyrophosphate crystals deposition in joint, that means the tophi will be because of calcium pyrophosphate crystals, and there will be an elevation of our serum uric acid, and that is called as pseudogout. I hope you understand the full thing, that is how this gout has came into the life. Then how we can treat gout? There are certain medicines we can use for gout. That is, the first medicine is allopurinol, which is used in the case of primary gout. Allopurinol is the structural analogous of hypoxanthine. This hypoxanthine is competitively inhibit the enzyme xanthine oxidase. So, if we replace this hypoxanthine with allopurinol, what will happen? The enzyme xanthine oxidase will not be inhibited, and we will see the gout will be treated like that. So, allopurinol is oxidized to alloxanthine by xanthine oxidase, and inhibition of xanthine oxidase by allopurinol leads to the accumulation of hypoxanthine and xanthine than uric acid, and these two compounds are more soluble than uric acid. So, it is very easy to excrete out these type of compounds instead of uric acid. I told you in the previous slide that uric acid is water soluble, so it is easily excreted. Now, these two compounds, that is alloxanthine and one is alloxanthine and the other is xanthine oxidase. Xanthine oxidase is the enzyme. So, inhibition of this xanthine oxidase by allopurinol, which leads to the accumulation of hypoxanthine and xanthine, and these two compounds are more soluble than uric acid. So, they are finally and easily excreted. Restriction of our dietary intake can also give us relief from gout, and dietary intake of what? Dietary intake of purines and alcohol. If we consume a lot of water, plenty of water is consumed, then there will be relief from gout, and anti-inflammatory medicines for pain relieving like colchicine, phenylbutazone, indomethacin, oxyphenylbutazone and corticosteroid. If used, then we can treat gout. So, several things we have to incorporate in our daily life to treat gout. First is the medicine, that is allopurinol. The allopurinol is an structural analogous of hypoxanthine and it gives inhibition of xanthine oxidase by allopurinol leads to accumulation of hypoxanthine and xanthine, and these two things are easily excreted from the body. Then the second thing is, if we do restrictions in dietary intake of purines and alcohol, and if we consume a plenty of water, and the final, that is anti-inflammatory drugs like colchicine, phenylbutazone, indomethacin, oxyphenylbutazone, oxyphenbutazone and corticosteroids. So, this was our treatment of gout. Let us discuss our pyrimidine nucleotide disorders. We have studied that pyrimidine synthesis is a simpler process than purine nucleotide. There are certain things in the purine structure we know, through which we can easily say that these things should be there for the synthesis of nucleotide, and then there is a degradation of pyrimidine nucleotide. The last product, the end product of pyrimidine nucleotides are, first is beta alanine and beta amino isobutyrate, which ultimately and lastly produce our acetyl coenzyme A and succinyl coenzyme A. So, we need to look after these 4 compounds, especially these 2 compounds, beta alanine and beta amino isobutyrate. Let us see. First, when we were discussing our biosynthesis pathway of pyrimidine nucleotide, I told you about one thing, that was orotate. So, if there is a problem of feedback mechanism and overproduction and accumulation of that orotate in our body, then there is a problem called as orotic aciduria happens. Now, what is happening here? In orotic aciduria, it is a rare metabolic disorder which is characterized by the excretion of orotic acid in urine. That means there is a overproduction of orotic acid or orotate in the blood, which has came into figure when there is excreted a huge amount of orotic acid in urine, then we called it the thing that is orotic aciduria. In this step, we can see the patient is having severe anemia and retarded growth. That means a person, when he is long into orotic aciduria, then we will see severe anemia and retarded growth. And it is happening because there is a deficiency of enzyme orotate phosphoribosyl transferase and OMP decarboxylase. So, these 2 enzymes, if there is a deficiency of these 2 enzymes, which enzymes? Orotate phosphoribosyl transferase and OMP decarboxylase of pyrimidine synthesis. So, if we correct these 2 things, deficiency, if there is no more deficiency of these 2 enzymes, then this disease can be cured. How we can treat it? Feeding diet which is rich in pyrimidine nucleotide, that is uridine or cytidine. These compound definitely, because there is a deficiency. If we give more pyrimidine nucleotide in the diet, that is uridine and cytidine, then this disease, this disorder will be overcome. And UTP also inhibits our CPS2 when blocks the synthesis of orotic acid. So, UTP, the presence of UTP, which ultimately inhibits the carbamoyl phosphate synthetase 2, which ultimately blocks our orotic acid, and then there will be no presence of or very less presence of orotic acid in the urine. And the second disease in pyrimidine nucleotide we have seen, that is we will be seeing, that is Ray's syndrome. It is also called as secondary orotic aciduria. That means it is an elevated, or you can say it is the next step, next stage of orotic aciduria. That's why they are called as secondary orotic aciduria, in which it is believed that the defect in ornithine transcarbamylase, which you have studied in urea cycle, causes the accumulation of carbamoyl phosphate. This is then diverted for the increased synthesis and excretion of orotic acid. That means this disease, this Ray's syndrome is not produced here when there is a problem in pyrimidine nucleotide synthesis. It has came way back from urea cycle. If there is a defect in urea cycle, that is the ornithine transcarbamylase step, there will be accumulation of carbamoyl phosphate and ultimately it give rise to our synthesis and excretion of orotic acid. So, this was all about in this lecture. Hope you enjoyed the lecture. Thank you.